I am presenting the case of Mrs. MN. She is 35-year-old female, resident of Delhi, postgraduate by education and environmental economist by profession. She got married in 2021 and she presented to our hospital with chief complaints of bilateral lower limb swelling since 2 months, decreased urine output since 1 month and shortness of breath since 7 days. I would like to date back my history to 2 years ago when she had first symptoms. Patient found herself to be pregnant in the month of January 2023 by doing a urine pregnancy test which she did at home, and then she visited a local obstetrician who advised her preliminary evaluation as a part of antenatal checkup. On initial evaluation, she underwent a ultrasound scan showing 8 weeks of live conceptors, and her blood pressure was checked, which was 130/80 at this time. Her creatinine was checked, which was 1.42 at this time, and the urine dipstick showed proteinuria 2+. She was then referred to a local physician nearby who advised her to maintain hydration, and that creatinine was increased due to some dehydration, and advised her to maintain hydration. At 9 weeks of period of gestation, the patient noticed some swelling in both eyes and facial puffiness in the morning, which used to subside during the daytime. She again visited the same physician and was told that her swelling was due to the leakage of protein in the urine. By this time, she did not have any history of leaking PV, bleeding PV, any history of recurrent vomiting, any history of decreased urine output. She completed her first trimester, and at 14 weeks of pregnancy, she complained of swelling of bilateral lower limb, which was extending from ankle to mid calves and gradually increased. She was told that her blood pressure was raised, and she was prescribed tablet labetalol 200 mg twice daily for her blood pressure control. She underwent the urine protein examination, that was also again 2+, and the creatinine at that time was 1.42. She underwent an ultrasound scan for fetal well-being and was suggestive of IUGR of the fetus, and also underwent a screening for chromosomal anomaly, which came out to be negative. Her blood pressure kept on rising during the period of second trimester, and her BP medications were increased from 2 times per day to 6 times per day gradually. She underwent again an ultrasound scan in 19 weeks of pregnancy, and it was suggestive of IUGR, and the fetal growth was lagging 2 weeks behind the normal growth. She had persistent progressive leg swelling, which progressed from ankle to calves to involving mid-thigh, and she had already gained 9 kgs from her pre-pregnant state till now. She did not have any history of decreased urine output till now. By the end of second trimester, 24 weeks of pregnancy, she underwent a USG Doppler scan, and it was suggestive of restriction of blood flow to the fetus. She was immediately referred to a tertiary care hospital in the Faridabad, and at that time she was told that her creatinine was around 2.5. She was immediately advised for termination of pregnancy in view of fetal distress and fetal compromise. She was administered injection Dexona for fetal lung maturation, and after 48 hours of admission, she underwent emergency LSCS in view of fetal distress. She delivered a baby boy that was 780 grams and was immediately shifted to NICU and kept on ventilator. During the course of these events, she did not have any history of bleeding PV or leaking PV, no history of any upper abdominal pain, no history of any upper yellowish discoloration of eye or urine, no history of any headache, decreased vision, blurring of vision, and no history of any decrease in appetite during pregnancy. When she regained consciousness after LSCS, she tells that her swelling was increased to an extent that the swelling was involving lower abdomen also. And her creatinine was told to be 5.8 at the time of LSCS. She was prescribed some IV diuretics, and her swelling kept on decreasing after that. After that, she was discharged with a creatinine of 5.8 and blood pressure medications to review after 2 weeks. She tells that her blood pressure kept on increasing even after the blood pressure medications, and she used to take 3 drugs for blood pressure control after that. Following that, after 2 months, her blood pressure gradually came down to 130/80, and her blood pressure, lower limb swelling gradually decreased. Her blood pressure medications were decreased and stopped gradually, and her creatinine came down to 3 milligram per deciliter. She was asymptomatic for 3 months without any medication. She did not underwent any blood test till March 2024. She did not have any history of any left swelling, decreased urine output by this time. By the end of March 2024, she had complaints of fever, cough, cold, and expectoration. She visited a nearby doctor and was told to have the pneumonia in her chest. So she was admitted, and her creatinine at that time was 6.2. And she was prescribed some IV medications for her raised potassium levels, and she was discharged after 4 to 5 days of antibiotics, and creatinine was 5.8 at the time of discharge. She was told that she remained asymptomatic after that without any leg swelling, and she visited a local nephrologist after 1 month, who investigated her for the cause of renal failure, and all tests including AMA, ENCA, CNCA were done, which were negative. And she was also told, she underwent the USG evaluation, and she was told that her both kidneys have shrunken. In the next visit in July, she was counseled for AV fistula creation, and she to start dialysis within months, which she refused. She had no symptoms. She switched to alternative therapy in the form of Ayurvedic medication. So she was then switched to pure vegetarian diet with nil protein intake according to her, and she remained asymptomatic till recently, in November 2024, when she had swelling in bilateral ligament involving mid calves. She did the creatinine by herself, which was found to be 7.4 at that time. She visited a nephrologist nearby and was prescribed some oral diuretics. By this time, her swellings decreased but did not completely disappear. She had complaint of cough and cold again and was prescribed some oral antibiotics for that, and her BP remained raised to around 160/100. She again had an episode of bleeding from nose, and which stopped on the blood pressure medication which she took. Her swelling gradually worsened over the period of 2 months, and she came to our hospital with complaints of swelling extending from ankle to thigh. And she also complained of worsening of shortness of breath, which used to occur while routine work initially, and which she felt during the strenuous work and progressing to the shortness of breath, difficulty in breathing while doing routine work. She did not have any history of PND, orthopnea, chest pain, no history of any abdominal distension or yellowish discoloration of eye. She tells that since past 2 months, she also has a history of itching all over her body, and which used to subside only after she scratched. She also gives a history of decreased urine output, which she noticed over the period of 1 month, and she tells that both the amount and frequency of the urine has decreased. Negative history during all this course, She did not have any history of rash, joint pain, hair loss, photosensitivity. No history of any change in color of urine or reddish color of urine. No history of passing any stones in the urine. Past history.
Yeah, completed.
She did not have any past history of diabetes. I would like to include the birth history in the this same past history. She was born premature at 8 months of age, and her mother, as she tells, the mother was also known to be hypertensive during the time of pregnancy, and she underwent emergency LSCS in your breaking period. She was kept in nursery for 2 days and then was discharged. She was asymptomatic till 19 years of age when she experienced some irregularity in her menses and was told that she had PCOD at that time. She took some medications, herbal medications for 1 year and then stopped. Her menstrual cycle became gradually uncontrolled. She did not have any history of recurrent UTI in the childhood. She did not have any history of blood transfusion in the past. No history of prior hospitalization in the past. Personal history, she has normal bowel habits, non-vegetarian by diet, non-smoker. She used to take occasional alcohol before illness, and there is history of snoring while sleeping. Family history, father is a known diabetic, mother is non-diabetic, non-hypertensive, but hypothyroid and takes treatment for it. Brother 5 years younger and with no known comorbidity.
That's it. Anything else you want to ask? Sorry? इतनी तो obsessive चली है. What do you want to ask? So she was married in 2021 and then January 23 she conceived, or the first pregnancy was detected. So apparently this was the only pregnancy she had. There's just a couple of points here. So your history, although you have given a very elaborate history, but I think you need to process this history. It's not necessary to tell each and everything whatever she has told. One, you said she has presented with chief complaints for last 2 months, and then you started with, say, present history date backs to January 23. Many times patient examiners would have some objection to it. Conventionally, your chief complaints and present illness should start at same time frame, right? So, even if you have to present this history, you can start that she had some kidney disease starting January, detected during pregnancy, and now she has presented with this and this complaint, and then you can say, okay, present history is starting from January 23 when she detected her pregnancy, and all this history what you have said, isn't it? But there is so much of limitation. She developed edema, she was given diuretic, edema subsided. She developed edema, given diuretics, edema subsided. So she had repeated episodes off and on edema for which she was prescribed diuretics and used to get symptomatic relief in between, but continue with the pregnancy. So little more processing of this history is required at this point of time. Understood?
So you chief complaints, you told bilateral lower limb swelling since 2 months, decreased urine output since 1 month, shortness of breath since 1 week. So when to use since, when to use for while enumerating your chief complaints? Anyone can tell?
Exact duration if we know, then it's since. If approximate time frame or we will use for.
Okay, so
anybody else? What you said is, I don't know, I didn't understand what you tried to say.
We know that she is having pedal edema since January 2025.
Exactly.
Then we will use since.
And if you are saying for 2 months, for 3 months, for 1 year, that is for. So if with exact reference to a particular point of time, then it is since. If you are just referring to a duration, then it is for.
Second thing, like you didn't elaborate your chief complaints. So you elaborated everything, but your chief complaints were not too much elaborated, as sir has already told. So what are the points we will ask in lower limb swelling? What are the points we will ask in decreased urine output? What are the points we will ask in shortness of breath? So you should tell one by one.
Sir, firstly, in the lower limb swelling, we will like to determine whether the cause of the swelling is due to
First is OPD, onset, duration, progression. This is the first thing we will ask. In every chief complaint, onset, duration, progression. Acute onset, gradual onset, this is very important, subacute onset. Then what is the duration, and then what is the progression. So every chief complaint we have to start with this thing. Then after that,
we'll determine whether what is the cause of swelling from the history wise. We would like to localize the symptom, the system which is involved.
no,
Like
you will.
cardiac.
You already told. We will then tell where the swelling was, as it's lower limb swelling. You told that how it progressed from ankle swelling, then it went upwards. It was ascending in nature. Then it involved the thorax, the sacral area also, as you told. Apart from that, what's important to ask?
Associated factor, aggravating factors, and leading
Yeah.
factors.
So we need to ask aggravating factors, relieving factors. So history presentation is just like we used to ask in MBBS days. So in super specialty, it doesn't change.
Little bit of more processing. Say for MBBS, for example, definitely what Dr. Sharma is saying. But at this stage, you can also say, okay, as you said, the swelling started 2 months before she has come to you. Started from leg, and then say over the period of 3 weeks or say 2 days or 5 days or 10 days, it progressed and involved the whole body. So that would also suffice, not necessarily कि फिर वो ankle तक पहुंची, फिर वो knee तक पहुंची, फिर वो thigh तक पहुंची, फिर वो abdomen में पहुंची, फिर वो face तक पहुंची. There is no need to describe in so much of detail, but at least some time frame how it progressed, whether it progressed in 1 or 2 days, or whether it progressed in 1 or 2 weeks, or in a month. So that will give us some idea of how these symptoms progressed during this time, right? And associated feature definitely, as you have already said, that it started with swelling, then there was decrease in output, and then shortness of breath. So obviously she had progressive edema which has progressed to NSARCA, leading to shortness of breath for 7 days before she was admitted to this hospital. Okay.
And sir, in shortness of breath also, we need to be very much elaborative. Like, what was the class, NYHA? Like, we need to ask that, I think, sir.
Yeah, definitely.
And what else we ask in shortness of breath? In cardiac cases, what we used to ask?
Cardiac case is basically gradual progression, basically at NYHA rate, and chest pain, palpitation.
Other associated symptoms,
PND.
वो तो आपने बताया था, orthopnea, PND, whether it is on the lying down or only on exertion, whether it was associated with expectoration, what type of expectoration, frothy, pink, so that it will give you an idea how severe is shortness of breath, whether it is amounting to pulmonary edema or it is just a. So what do you think her shortness of breath was because of?
Because of basically fluid overload.
Fluid overload, yeah, because associated with swelling. At times the way you have presented, it's quite possible that this is just lack of stamina. She has been on Ayurvedic medicines, no protein diet, gradually becoming weak and weak. So it could also be. At times it is important to differentiate whether it is just lack of stamina or this is general fluid overload. Okay. So what is your diagnosis?
I'd like to summarize.
Mm-hmm.
34-year-old woman diagnosed as having renal dysfunction during first trimester of pregnancy with significant proteinuria, was noted to be hypertensive at the time of pregnancy with poor blood pressure control, with deteriorating renal function. Came with signs and symptoms with symptoms of fluid overload. So the syndromic diagnosis would be chronic kidney disease
Mm-hmm.
with hypertension.
You think hypertension is different than chronic kidney disease, or it is part and parcel of chronic kidney disease? So you think she has chronic kidney disease now, which she has presented with probably advanced renal failure, ECF volume overload, isn't it? Okay. So coming back to your history, in January when for the first trimester she was found to have hypertension, proteinuria and renal dysfunction. What are the possibilities at that point of time? Say any woman who was first time detected to have hypertension, proteinuria and some sort of renal dysfunction, what are the major possibilities or differential diagnosis at that point of time?
Syndrome, it would be chronic kidney disease only. And
So one, it could be renal disease, renal parenchymal disease or renal disease or chronic kidney disease. So basically renal disease. What else?
another during the second trimester, she might be presenting with preeclampsia.
So hypertension in pregnancy, it could be pregnancy induced hypertension or preeclampsia. Okay.
But that time you told it's 8 weeks of fetus.
We will discuss that.
Yes, sir, yes, sir.
During pregnancy, let's talk broadly. So renal disease, pregnancy induced hypertension or preeclampsia. What else?
And the patient might also present with sudden worsening of renal function in cases of AKI, as a AKI.
So acute kidney injury. Okay.
There might be some worsening of the kidney disease, the worsening of renal function in acute onset, like in the late trimestral pregnancy in the form of HUSPT3.
So that will come to AKI in pregnancy. Okay, whether it is related to pregnancy or any other reason. So any new onset of kidney disease during pregnancy, pre-existing kidney disease which is just detected during pregnancy, or it may be associated with pregnancy, as you said, preeclampsia or say with different severity, mild, severe or eclampsia or syndromes which are related to pregnancy, right? Okay. So this patient has presented in first trimester of pregnancy. So what do you think is the possibility in this lady? Pre-existing chronic kidney disease. Okay. Was she ever examined before pregnancy?
No, sir.
No. Is it common?
Yes, sir, it is common. Around 3 to 6% of the population are chronic kidney disease who are diagnosed as in pregnancy.
Yeah. So it is quite common, especially in women. See, in India, generally, they do not have any contact with healthcare system before they conceive and they become pregnant. Most of these women are not employed. Usually, men, when they get employment, they get their first medical checkup. Generally, although the quality of that medical checkup is not very aggressive, they will just do say CBC and blood sugar and say X-ray chest. So, but that at least they have some sort of medical examination when they join job. Women, since most of these women do not join any jobs, they do not have any contact with healthcare system, and the first contact is generally during pregnancy when they conceive. Okay, so that the first contact, and that's when a lot of women are diagnosed to have underlying hypertension or chronic kidney disease or other diseases whatsoever it may be. So it's quite common. Can it be pregnancy-induced hypertension or preeclampsia? How would you differentiate between pre-existing renal disease and pregnancy-induced?
In a patient who is non-hypertensive and without any renal dysfunction, a preeclampsia generally appears after 20 weeks of pregnancy.
Mm-hmm.
And pre-existing hypertension or pre-existing chronic kidney disease usually present before that 20 weeks. And patients usually have increased response to this. The patient will have increased blood pressure during first trimester of pregnancy only in pre-existing chronic kidney disease.
What happened to blood pressure during pregnancy?
In the first trimester, the blood pressure usually falls.
When? At what time frame? What time of pregnancy?
First trimester. First trimester.
First trimester is 12 weeks. So even early, say what people say generally 6 to 8 weeks, usually they have a drop in blood pressure. Okay, so sometimes even if the patient is hypertensive beforehand, once they come in contact with gynecologists, they may have normal blood pressure, although they have history of pre-existing hypertension, but just by pregnancy, when they go to a healthcare system, they might have normal blood pressure, say 130/80, because by then already because of pregnancy, they may have a lower blood pressure, right? So it starts as early as 6 weeks or 8 weeks. So you may even miss pre-existing hypertension if you examine at that point of time. Okay. Then what happens to blood pressure?
Then gradually the blood pressure increases at around 20 weeks. It starts increasing. It normalizes.
Normalizes.
The systolic blood pressure gradually increases from the night.
Anyone else? What happens to blood pressure during normal pregnancy?
Sir, blood pressure starts dipping after 4 to 6 weeks of the pregnancy.
Mm-hmm.
Subsequently, it's at around 20 to 24 weeks.
Mm-hmm.
Then starts to increase to the pre-pregnancy level by around 34 to 36 weeks.
Yeah. Or it may still remain low and it becomes normal, say within say 8 weeks or 12 weeks of postpartum period, right? So the Nadar is around 20 weeks, 20 to 24 weeks, as he has very rightly said, and after that there is gradual recovery of blood pressure. It may become normal level at the time of delivery or maybe subsequently after delivery. And why does this blood pressure drop?
So there is basically multiple mechanisms. Firstly, there is increase in this volume. The volume increases. There is
Which volume increases?
total blood volume, and the glomerular filtration rate also increases initially. And there is
Why does the volume increases?
sir, there is the RAS system has low sensitivity in the pregnancy. It decreases the sensitivity of the RAS system, and the threshold response to ADH also decreases.
Mm-hmm.
Will it lead
So
to
what does
increased volume expansion?
What does ADH has to do with volume?
Any hormonal change in pregnancy?
The progesterone and relaxins are secreted, which will mediate vasodilatory response.
Yeah. So that will mediate vasodilatation, systemic vasodilatation. So systemic vascular resistance will decrease, and that's predominantly hormonal in origin because of pregnancy, and that is perceived as hypovolemia by the body. So body will mount all mechanism to compensate for this hypervolemia. So there is increase in heart rate, increase in cardiac output, increase in total blood volume. So a state of hyperdynamic circulation exists, and that also increases renal blood flow. Okay, so there is a significant increase in renal blood flow to the tunes of 30 to 40%. And with that renal blood flow, there is also increased GFR. So all these changes start early pregnancy and they continue till the end of the pregnancy. Okay, so these are hemodynamic changes which occur. What happens to ADH? You brought ADH.
So the threshold of the volume regulation, the serum osmolality is fixed to a lower set point.
Why? Osmoregulation and volume regulation are two different things. So we have talked about volume regulation. That's why they retain a lot of salt and water and they are hyperdynamic circulation. What happened to ADH? vasopressinase. So this is the enzyme which is released from placenta, and that leads to excessive metabolism of arginine vasopressin or ADH, which you call, okay, and that reset their osmostat. So they will have relative hyponatremia. And what other changes occur in pregnancy? What happened to respiration?
The respiratory rate increases due to the diaphragmatic expression of the gravity uterus.
That will occur very late in pregnancy.
And there is a respiratory alkalosis.
Yeah. So, and that again start early, right? So, not because of diaphragmatic involvement, but again because of hormonal involvement, hormonal changes which occur during pregnancy. There is stimulation of respiratory center and they hyperventilate. So, they have mild respiratory alkalosis. PCO2 will be lower, bicarbonate will be lower, right? What are the changes in kidneys? Normal changes during pregnancy?
Normally the renal plasma blood flow increases and the GFR increases
GFR.
to 30 to 40%, and there is fall in the creatinine, and generally it is considered that if it is more than 0.81, it is suggesting some underlying kidney disease.
Yeah.
And
So, the normal level of creatinine is somewhere around 0.4 or 0.5 in pregnancy. So, if it is more than 0.8, that indicates that this compensatory response has not occurred, or the GFR is lower than what it is expected to be, right. So, creatinine more than 0.8 is abnormal. If you see more than 0.8 during pregnancy, there is something wrong with the kidneys.
Any
And-
difference in trimesters in the creatinine level in 3 trimesters?
So in first trimester it is usually lower, and gradually the GFR initially increases, and then there is a declining phase in the GFR, return to the normal pre-pregnant state. So
In different studies, it has been found that in first trimester it's slightly higher, then lower in second, then slightly higher in third.
And what else?
and there is increased absorption of the water and salt from the this renal tubules.
Increase absorption.
And there is physiological stasis of this urine in the renal tubular due to the effect of this progesterone and
So, again because of hormonal changes, relaxin, there is dilatation of PCS, okay. So, pelvic ileal system.
glomerulomegaly, and increase in the size of bilateral kidneys.
So, increased blood flow, hyperfiltration, increased size of the kidneys, and if you do the biopsy, you would find glomerulomegaly and histopathology.
Glomerulomegaly and tubular swelling.
No. Endotheliosis. So, swelling of endothelial cells. So, they are also the endotheliosis. This may be normal. Okay. Proteinuria. So, as there is hyperfiltration, increased GFR, there is also increased amount of protein excretion during pregnancy. So, normally, what is the normal protein excretion?
Normal adults have less than 150 milligram
Of
per day
proteins,
proteins, and albumin less than 30.
less than 30. So, what happens in pregnancy?
In pregnant state, it is usually considered that more than 300.
Yeah,
protein
so it may increase from 150 to 300, which may be just normal, physiological. But if it is more than 300, then definitely you get alarmed that there is something wrong with the kidneys, and that's the reason there is proteinuria in the urine. So, these are the normal changes which occur during pregnancy. Okay. Weight gain?
weight gain is around 10 kgs approximately.
What trimester?
First trimester it is usually 1 to 2 kgs, and then second trimester 5 kgs, and around third trimester also 5 kgs.
Yeah. So, usually maximum weight gain occurs in second half of pregnancy. In first half, the ballpark is generally 0.5 kilogram per month, and then subsequently in second half of pregnancy it may be say 1 kilogram every month, and the total weight gain in first pregnancy is around 10 to 12, whereas in subsequent pregnancies it may be just 7-8 kilograms during pregnancy. Okay. So can the preeclampsia occur in first trimester?
Generally, it does not occur. मतलब it does not occur
In what condition can it occur?
in
Pre-existing chronic kidney disease.
The preeclampsia may precede the 20 weeks.
Yeah, so less than 20 weeks onset. What else?
In case of this non-hydatidform mole,
Hydatidform mole,
twin pregnancy,
twin pregnancies.
and
Yeah, so I think these are, which are again high progesterone state. So hydatidform moles, twin pregnancies, underlying disease. So not necessarily just chronic kidney disease, even chronic hypertension, diabetes, elderly primary. So if somebody is becoming pregnant after 40 years for the first time, that also can precipitate. So these are the maternal factors which can lead to preeclampsia, and that can occur even before 20 weeks. In a normal circumstances, generally it is after 20 weeks. So one is the time frame. So if there is hypertension in first trimester or before 20 weeks, you should consider other factors. If it is after 20 weeks, it could be preeclampsia. What else? What else will differentiate whether this is preeclampsia or hypertension or CKD?
there are new development of serum markers which can be done.
Okay.
Like
Clinically?
clinically, we can do a renal function test also.
So what will happen to renal function test? How will it help you decide whether this is hypertension or preeclampsia?
It may be increased in cases of hypertension, pre-existing hypertension.
Why? If they do not have chronic kidney disease, just say chronic hypertension, what will happen to creatinine? It will be normal, right? If they have underlying chronic kidney disease, then it may be that they have chronic kidney disease and they have high creatinine. But if it is chronic hypertension, they would have normal creatinine. Whereas in pregnancy associated eclampsia, there will be higher creatinine, because preeclampsia is associated with decreased GFR. So as you have said, the normal serum creatinine is less than 0.8, so it may be more than 0.8 in such situation. If the creatinine is 2,
At the time of after
diagnosis, say you've seen this patient at say 26 weeks. For the first time she was found to have hypertension. So as you said, the possibility is pregnancy associated hypertension or preeclampsia, but you did the creatinine and creatinine is 2 milligram per deciliter. She has 2 plus proteinuria, as you said. So now, is it preeclampsia, chronic hypertension or chronic kidney disease?
So it can be both chronic kidney disease or preeclampsia.
How will you differentiate them?
We can do another markers for this, another things for this preeclampsia and chronic kidney disease. Like there may be another involvements of
Other end organ involvement, because the preeclampsia is a systemic disease. So it's not just the kidneys. So normally, if this is general garden variety or say preeclampsia with mild disease, you should not have renal dysfunction. If at all, renal dysfunction will be mild. Say creatinine may be more than 0.8, but at least less than 1 or 1.1. Right? If the patient has severe preeclampsia, they will have other symptoms, as you said in your negative history, that epigastric pain, vomiting, nausea, CNS symptoms, visual symptoms, right? So these things will be there. If you do investigation, you will find high uric acid level, increased liver enzymes, right, and increased creatinine. But still, if it is uncomplicated preeclampsia, creatinine will not be more than, say, 1.75, 1.8 or 2, unless until it is like severe impending eclampsia or severe preeclampsia, and that becomes an emergency then, right? If the patient is not so symptomatic, no other end organ involvement, just creatinine of 2 with proteinuria, then quite likely that this is underlying chronic kidney disease, which is just detected now. Okay. So how will you differentiate then? आप बताओ ना, आप जो investigations बता रहे थे.
Soluble FMS like tyrosine kinase and placenta-induced growth factor. This ratio is done, and this happens because of the resistive index of the vessels of the placenta are converted from capacitance vessels to resistive vessels, and this ratio is generally found more than 40 is significant.
So that if this is high, that indicates preeclampsia. If it is not high, it may not be preeclampsia. And Doppler, placental Doppler and placental blood flow. See, preeclampsia is a state of abnormal placentation. So when the placenta attached to uterus, there is abnormality at that point of time. It may be because of fetal factor, abnormality in the fetus, genetic abnormality or anything. So there is no proper placentation and decreased blood flow to the placenta, or it may be because of maternal factor, as we have just enumerated, right. Generally, if it is because of fetal factor, it occurs early. If it is because of maternal factor, it may occur little later. But there is definitely abnormal placentation and abnormal flow to the placenta. So you do a uterine Doppler. If you find there is abnormal flow, you do these level, soluble Flint and PGI, and if it is also high, that will give you an idea, okay, this is abnormal placentation plus other clinical features, this is preeclampsia. Whereas if ratio is normal, Doppler is normal, patient only have high blood pressure, some proteinuria, high creatinine, that indicate that patient probably has underlying chronic kidney disease, and then you investigate according to chronic kidney disease, what type of kidney disease she has. So what happens, what has gone wrong with this lady?
One extra factor, sir, what happens to the amniotic fluid level? Usually when there is in a CKD patient, there is oligohydramnios. Polyhydramnios. Why so?
So the polyhydramnios होगा ना फिर तो उसमें.
Poly, yeah.
आपने poly बोला, oligo बोला?
Poly, sir. Because urea, the fetus assumes it as a osmotic diuretic.
So if you are managing this patient, what has gone wrong with this lady?
Sir, firstly, she was told that her creatinine was due to basic dehydration in the first trimester only. She, if I were there, then I would have given her 3 risk factors, including the fetal risk, maternal risk, and progressive renal decline risk.
So one was the diagnosis. See, that is again indicates lack of awareness. See, as a specialist, now you can say that, okay, for the first time at 8 weeks when she was found to have high blood pressure, high creatinine, urine protein, she had chronic kidney disease, underlying chronic kidney disease, which was not diagnosed by the obstetrician, not referred to the specialist, referred to the general physician. He also was ignorant and he could not pinpoint the diagnosis. So the missed diagnosis at that point of time. If they would have diagnosed her at that point of time, probably that would have prevented her from so much of agony which she has gone through. Isn't it? So, that is very important for all the specialities to understand that this is an opportunity to diagnose chronic kidney disease. This is the first encounter of this lady with the healthcare system, and we as a healthcare system has failed to diagnose her at that point of time. Isn't it? Suppose you have diagnosed that lady at that point of time. Now, the second question which she will ask is, now what should I do with pregnancy? What will happen to me?
Sir, I would give her 3 risk factors. The pregnancy associated risk factor to herself, the progressive renal decline during the pregnancy, and I would also give the risk to the fetus born prematurely, and the risk of intrauterine death also, and would also give the progressive renal decline in this patient. So,
Yeah, so what we generally say, like effect of pregnancy on the mother, effect of pregnancy on the fetus, and then effect of pregnancy on her kidney disease. Okay. So, taking one by one, say what is the effect? If the mother has chronic kidney disease, what are the problem with the continuation of pregnancy in terms of fetal outcome?
in terms of fetal outcome, there are increased risk of cesarean delivery, increased risk of premature delivery, increased risk of intrauterine death, increased risk of chromosomal abnormality.
Chromosomal abnormality. Why? Why chromosomal abnormalities?
Increased age.
Chromosomal abnormality can occur, say if the patient has underlying kidney disease or increased age first time, they would have problem conceiving. Okay. Many women, if they have advanced stages of renal failure, they will become anuric. They will have problem conceiving. Even if they conceive, because the ovum is not good quality, there are chromosomal abnormalities in the ovum, they will have loss of pregnancy in early, say spontaneous abortion, lack of proper placentation. So, they will lose this pregnancy in early, say within first trimester. That is very common in patients who have chronic kidney disease. But now that she has conceived, that means her kidney disease is not that severe, and that is the reason she has conceived naturally. What will happen later? As you said, there may be, and which happened in this lady, intrauterine growth retardation, the fetus will not grow properly. Okay. There may be intrauterine death and premature evacuation. Even if the fetus grow, there will be premature labor, fresh stillbirth, more risk for cesarean section, which is generally same as in other pregnancy, but maybe slightly more risk of cesarean section. So, these are the problem with the fetus. So, all of these has happened in this lady. She had intrauterine growth retardation, she had fetal distress leading to emergency LSCS, small for date baby 720 milligram, 780 milligram. Okay. What happened to this fetus? The child surviving?
Child survival, sir.
Okay. So, that can happen to fetus. Okay. To mother?
Mother, there are increased risk of preeclampsia occurring early in the pregnancy, and there will be increased risk of complications associated with all the preeclampsia.
So, she may have increased risk of preeclampsia, increased risk of severe preeclampsia and complications because of that. And
Progression of CKD, faster progression.
Faster progression of CKD, faster fall in eGFR.
okay. So, should I terminate this pregnancy? Should I continue?
It's the patient's choice.
So, she is asking you, you should have to guide her. शी इज़ 8 weeks प्रेगनेंट, शी इज़ फाउंड टू हैव रीनल फेलियर. आपने उसको बताया कि साहब तुम्हें तो रीनल फेलियर है डॉक्टर साहब, अब क्या करूँ, मैं अभी टर्मिनेट कर दूँ या मैं कंटिन्यू करूँ. So what are the factors which will determine all these complications which you have enumerated?
Sir, there are basically three factors: the pre-pregnant state EGFR,
Which you don't know.
which we don't,
Okay.
and pre-pregnant state proteinuria, and the hypertension of pre-pregnant state.
So let us say now you don't know all these things when she was not pregnant, but this is the first time she has come to you and she is pregnant. So her creatinine you said is 1.42, her urine protein is 2 plus, her blood pressure is 130/80. So where will you grade her? Chances of successful outcome. Stage 1, 2, 3 तो होती नहीं इसमें. नहीं तो CKD तो है, उसका रिस्क कितना है. Said the patient is asking you a very simple question. डॉक्टर साहब मैं कंटिन्यू करूं या मैं अभी टर्मिनेट कर दूं, मेरा ऑप्शंस क्या हैं. अभी टर्मिनेट कर दूंगी तो आगे क्या होगा, आगे दोबारा कंसीव करूंगी कि नहीं करूंगी, वो सेकंड क्वेश्चन है, अभी इसके बाद आएगा. अभी तो पहले इस प्रेगनेंसी का बताओ. तो what background you have to tell her or to guide her?
30% risk of progression.
अभी प्रोग्रेशन की तो अभी तो सक्सेसफुल क्लिनिकल आउटकम की बात कर रहे हैं. चलो, सो एज यू सेड दीज थ्री फैक्टर्स, द लेवल ऑफ GFR, proteinuria and hypertension. If the hypertension is very bad, again the chances of adverse outcome is very high. If the hypertension is well controlled with minimum amount of medicines, the chances are low, right? So same way, proteinuria, the proteinuria is less than 1 gram, or if the proteinuria is more than 1 gram or proteinuria is more than 3 gram, accordingly there is higher and higher incidence of adverse outcome. GFR more than 60 ml, less than 60 ml, less than 45 ml, right? To the tune of, if the patient GFR is more than 60 ml, the chances of adverse outcome may be 2 to 3, not very less, 2 to 3 times of normal. If you have to give them successful, maybe say in the normal pregnancy you say there is a 1% chance of adverse outcome, 99% you will have a favorable outcome. But in these patients you will give them say 90% chances are that you will have a good outcome, otherwise there is 10% chance that you may have some problem to the mother or to the fetus. If the GFR is less than 45, say less than 60, it will be somewhere around 25 to 30%. If GFR is less than 45, which amounts to serum creatinine of more than 2, then there is only 50% chance. The chances of adverse outcome are very high. Same thing happens with proteinuria and same thing happens with, and if there are multiple factors together, then obviously it gets worse. So at this point of time, if you say, okay, this may be her pre-pregnant level or maybe slightly more than this, she would be mild to moderate risk of adverse outcome. Okay. So one should continue with this pregnancy if she really wants to continue with family, but you will closely monitor this for other problems. Okay. How will you monitor? She has decided, she has taken your advice. Okay, doctor साहब, आपके हाथ में है अब सब कुछ, आप बताइए क्या करना है. ऐसे ही होता है क्लिनिक में. ट्वाइस वीकली तो हॉस्पिटल में एडमिट कर लो यार, 8 हफ्ते पे आई है, 9 महीने तक चलना है उसको. अभी
4 weeks during the first trimester of pregnancy, 4 weekly, and then after 20 weeks we will call her
more frequently, yeah, twice per month,
twice.
right? So initially in this trimester you will monitor her say once in a month, but maybe in second half of pregnancy you will increase the frequency, so maybe once in 2 weeks. Okay. What will you do during these visits?
During these
What medication?
The pregnancy safe medication. If she was taking ACRB, we will discontinue that and we will switch her to the safer medications like beta blocker, levotalol, methydopa, and nifedipine, and hydralazine, which are usually considered safer in pregnancy.
Only nifedipine or any other calcium channel blocker? Nicardia is nifedipine. Any calcium channel blocker, not necessarily nifedipine. Nifedipine was there earlier, but then since nifedipine, some patient may not tolerate nifedipine, there are a lot of side effects. It's a short acting, although you have a retard formulation, slow release formulation, but still. So if there are other medications, for example, my favorite is amlodipine. So if patient can take nifedipine, they can also take amlodipine. So calcium channel blockers, among beta blockers, you said levotalol. What is the problem with others?
These are basically longer acting. The levotalol is shorter acting ones, and the dose titration is very wide range of dose titration. It can be given from 200 mg to 1200 mg.
That is also true for other beta blockers.
Increase incidence of bradycardia.
Fetal bradycardia. So in late pregnancy, right? So what you are saying, these medicines are recommended for preeclampsia, considering that preeclampsia will occur in late pregnancy. Okay, so that's why you want to give them a short acting or say levotalol. But if the patient have chronic hypertension like this, you can even use other antibiotics. You might monitor for bradycardia, or you can stop that later in pregnancy. When the lady is nearing delivery, you can stop beta blocker and change to some other medications. Right? So, but there is no harm in giving any other beta blocker as well in this stage of pregnancy. What else? So, you will give levotalol, calcium channel blocker. If not controlled, you will give hydralazine and methyl dopa तो available नहीं है फिर आप लोग की फेवरेट दवा सबकी फेवरेट है वो दे सकते हैं कि नहीं दे सकते हैं दे सकते हैं अगर बहुत सिवियर हाइपरटेंशन है तो इट्स नॉट अ प्रेफर्ड मेडिसिन बिकॉज ऑफ इट्स साइड इफेक्ट प्रोफाइल बट इफ द पेशेंट हैव chronic hypertension which is not being controlled with other medications, you can give. Okay. Diuretic?
Diuretics are usually avoided.
Okay. Why?
Because they have incidence of this fetal malformation and oligohydramnios associated, and they have ototoxicity also, which are ototoxic.
High dose diuretics. Okay. Again, this is again in context of preeclampsia and chronic hypertension. In preeclampsia, generally there is decreased perfusion. Okay. So in these patients, if you give diuretic, that will worsen their preeclampsia and placental perfusion. Whereas if patients have chronic hypertension and they are volume overloaded, you can give them diuretic to control their blood pressure. So there is a differentiation. If you are treating chronic hypertension or chronic kidney disease and the patient is volume overloaded, you can give them diuretic. But if the patient has preeclampsia, then diuretics are not the agent of choice. Okay, it's already the state of volume depletion and decreased placental perfusion. Target blood pressure?
Less than 115 by 75.
Less than 115 by 75. गायनेकोलॉजिस्ट तुम्हें भगा देगी कहाँ से आ गया नेफ्रोलॉजिस्ट मेरा बच्चा ग्रो कैसे करेगा
There are various guidelines. Previously, the NICE guideline and the US guideline suggest less than up to 160/100 they used to suggest. Now it is recommended to keep less than 130.
Yes. So you should not keep it high. As you said, 160, 100 is hypertension. Okay, and the patient will be symptomatic. If it is preeclampsia, patient will be severely symptomatic. So you should definitely bring it down to less than 140/90, preferably 130/80, but don't bring it down to 120 or 115. That will decrease the placental perfusion again and will hamper the growth of child. So no gynecologist will like that low blood pressure. Right?
Diastolic should not be less than 70.
Yeah. So just maintain it within normal range, but not too low. What else you will do?
We monitor her for another organ involvement like liver. We'll monitor the LFTs for the patient. We'll monitor her for any visual abnormalities or visual disturbances like scotoma, headache, any blindness happening.
And
We'll check for the level of proteinuria worsening.
mm-hmm.
You will
Uric
check for-
acid. Sorry.
No, I was asking, you will check for pallor, hemoglobin levels.
Hemoglobin will optimize her for any anemia. Usually this IV iron and erythropoietin are safe in pregnancy
If required.
if required.
So that is generally the patient, if they have this type of renal insufficiency, they won't have anemia because of renal disease. If at all, this will be nutritional anemia, right? And once they become amenorrheic during pregnancy, that is the nature's way to retain their hemoglobin and iron level. But still, you may require to give them oral iron, and if they have severe iron deficiency, you can give IV iron. If IV iron, what type of iron?
Carboxymaltose,
Has not been tested in females in pregnancy.
iron sucrose.
Sucrose. Okay, so generally, because that has been used in pregnancy, whereas these newer iron preparations have not been used. So, but both are sugar, so maybe you can give it, but there are no data. Erythropoietin, if at all it is required, generally that is given in patients who are on dialysis if they conceive, but in patients at this stage probably should not require too much of ESAs. Okay. Nutrition?
Nutrition in the form of increased dietary protein intake and folic acid, calcium, iron supplements.
With kidney disease?
With kidney disease, we would like to check for this MBD part also.
MBD part. What?
Vitamin D deficiency, we would like to replace that.
Nutritional deficiency. Again, at this point of time, she is not expected to have a florid CKD, MBD or any. If at all mild biochemical abnormality, I won't bother unless until she has hyperphosphatemia or anything. So calcium supplementation or vitamin D supplementation as far as nutritional supplementation is required. What about protein intake? She has chronic kidney disease.
It is recommended it should increase to more than 1 gram.
What will happen to her chronic kidney disease? Right? Saurabh Puri? 8 हफ्ते पे तुम्हारे पास आई थी, क्रॉनिक किडनी डिजीज था इसको. प्रोटीन खाएं कि नहीं खाएं? एक हमारी आंटी जी हैं, उन्होंने कहा तुम्हें किडनी की डिजीज है तो तुम तो दाल खाना बंद कर दो. चलो अब की बारी डॉक्टर साहब से पूछेंगे. 1.5 to 1.8. So from where is this figure coming?
That is in dialysis. That is 1.8 gram per kg per day. The weight is pre-pregnancy weight plus 20 gram of protein, extra protein. That is in dialysis patients. Patients on dialysis.
What is the recommendation for normal individual? Chalo.
1 gram per kg per day. For normal, 1 gram per kg per day.
1 gram per kilogram per day. So that is normal or minimum? That is not desired. What is it called? Recommended dietary allowance, RDA. Okay, that is recommended dietary allowance to prevent negative nitrogen balance. If you take less than 1 gram, there is a risk of negative nitrogen balance in case of acute illness. Maybe in a basal condition you may maintain nitrogen balance, but the moment you have acute intercurrent illness you might go into negative. So this is the minimum protein intake which a normal individual should have. Right? What is the normal protein intake in India? Less than 0.8. There are studies where people have assessed protein intake in normal population. So generally it is 0.5 to 0.6, not more than that. Maybe there are occasional individuals. So if you make a normal distribution curve, so maybe 10% people who will take more, but 90% people will take less than 0.8, and the average is somewhere around 0.5 to 0.6, which is way below protein intake. Okay. So any patients who have chronic kidney disease, there is no need to restrict protein, unless until somebody is in that higher 10% where they are taking lot of protein for some reason. Maybe somebody is going to gym, or somebody wants to be muscle builder or something. You may have to individualize, talk to the patient, find out how much protein they take. Most of the time, more than 90%, you will have to increase the protein intake rather than decreasing protein intake. So it is a myth that you need to cut down on protein. You should ask them to increase protein intake. This lady, 1.4 creatinine, 8 weeks of pregnancy, she needs protein. Don't restrict protein. She needs protein for herself, she needs protein for the fetus. Okay? So at least 1 gram per kilogram. So preferably more than that. So as Dr. Sharma said, at least 20% additional allowance. So the minimum 1.2 gram per kilogram protein she must take. You've seen gynecologists giving amino acid infusions? देखें कि नहीं देखें? In the normal individual, whenever there is IUGR, whenever less fetal growth, they give amino acid so that there is some nutrition to the fetus. So that's what you have to do here. Don't restrict her protein, give her protein, extra protein. She needs protein. You may have to ask her to restrict her salt and water and other things, but at least give her protein. Don't restrict protein. That's what very important. Right? Chaliye. So with all this care you have carried, you have prevented all complication, and she had a premature delivery. Now what happened?
So one question, sir.
Sure.
At that level, like we don't know the ultrasound later on came that bilateral kidneys are shrunken. At that level, when 8 week of fetus is there, someone told her that she needs to undergo kidney biopsy. Will you do, and why not, and why so?
इलाज तो हो रहा है, पता तो है नहीं तुम्हें किडनी में खराबी क्या है.
Why not? It's a nephritic syndrome.
Firstly, it would present like rapidly deteriorating renal function. In case of nephritic syndrome, there would be other abnormalities like hypertension would be.
हाइपरटेंशन तो है इसको.
Markedly reduced hypertension, the other uncontrolled hypertension could present like these.
So what are the indication to do a biopsy or intervene?
So we would
Chronic kidney disease तो है. अब आप उसको कंजर्वेटिव मैनेज कर लो एज पेशेंट के साथ. हमें तो पता नहीं वजह क्या है किडनी की. नॉर्मल कोर्स में आप उसकी बायोप्सी कर देते. अब इसको बायोप्सी आप नहीं कर रहे हो तो क्यों नहीं कर रहे हो, और कब आप करोगे कि भैया कम वॉट में नाउ आई हैव टू डू बायोप्सी, आई कांट वेट.
if the diagnosis would guide us in a treatment, and that would
So what will be that condition?
like in case of lupus, known lupus nephritis, and if there is worsening of the renal function
In form of
in the form of
सीरम क्रिएटिनिन बढ़ता जा रहा है और प्रोटीनूरिया वर्सन होता जा रहा है, डिफिकल्ट टू मैनेज। पोस्ट ट्रांसप्लांट की तो अभी बात ही नहीं हो रही, अभी तो नेटिव किडनी की बात हो रही है। खाली नेफ्रोटिक रेंज प्रोटीनूरिया आई वोंट बॉदर। अगर नॉर्मल किडनी फंक्शन है और कोई प्रॉब्लम नहीं, नेफ्रोटिक रेंज प्रोटीनूरिया हुआ करे, बाद में टैकल कर लेंगे, कौन सी इमरजेंसी है। वेयर यू फील दैट द किडनी इज थ्रेटेंड, आई कांट वेट फॉर 9 months। एक्टिव प्रोलिफरेटिव ग्लोमेरुलर नेफ्राइटिस, अगर आपको आरबीसीज हैं, आरबीसीज कास्ट हैं, रैपिडली राइजिंग सीरम क्रिएटिनिन है, और एनी सिस्टमिक डिजीज जैसे आपने बताया लूपस है, यू नो दैट देयर इज लूपस फ्लेयर एंड ऑल्सो अ रीनल फ्लेयर, वेयर इफ आई विल नॉट ट्रीट नाउ द किडनी इज थ्रेटेंड, राइट। इन दैट केस यू कैन डू अ बायोप्सी। Preferably, अगर if you have to do a biopsy, second trimester is the safest period where you can do the biopsy, right? If you can't do biopsy, then such situation, but still you can't do biopsy. Still lupus ही है, she is a known patient of lupus. अब आपको लग रहा है ये mid trimester में आके कि इसको तो ये कुछ फ्लेयर हो रहा है, like
steroids,
and
if she is on azathioprine, we can give, मतलब she might be on that only, she has conceived, and
यही ऑप्शन है, स्टेरॉइड ही दे सकते हो आप, ठीक है। अगर फिर भी आपको लग रहा है कि भाई किडनी थ्रेटेंड है, देन यू विल हैव टू टर्मिनेट द प्रेगनेंसी एंड देन मैनेज द रीनल डिजीज, राइट। बट स्टेरॉइड कैन बी गिवन इफ यू आर सस्पेक्टिंग फ्लेयर और डिजीज, यू कैन गिव देम स्टेरॉइड। But if it is a real threat to the kidney, then you might have to terminate the pregnancy and then do the biopsy and treat accordingly, whatever is required. Okay? So you should know when to do the biopsy and when to wait. आगे क्या हुआ? डिलीवरी हो गई 24 वीक्स पे LSCS। अब क्या करें?
We can start on that, and we'll closely monitor her for renal deterioration, and we can prescribe diuretics
if required. अगर वॉल्यूम ओवरलोड होगा तभी तो करोगे। Now you want to establish the diagnosis or not? So far we don't know what is the renal disease. So now that she has delivered, you will follow her for say 4 weeks or 6 weeks. Okay. One thing is to differentiate whether if you are still not sure whether it was preeclampsia or renal disease or hypertension. If the changes revert to normal within 4 to 6 weeks, it's quite likely that this was just preeclampsia. But if they persist, it's quite likely that this is underlying chronic kidney disease. In this patient, you are more or less convinced that this is underlying chronic kidney disease. You have managed her through pregnancy. Now she is delivered. Now focus on kidney disease. So you do an ultrasound, you do other things, and you do the biopsy if possible. अगर बिल्कुल small kidney है, that's a different issue. But if he has reasonable good kidney, then you will do the biopsy and try to establish the kidney disease, and then manage accordingly. Whatever is required, ACE inhibitors, ARBs, or what else is required, you will manage accordingly and follow her closely. That again was not done in this lady.
In March 24, you told she developed LRTI, and as per her, you mentioned she had pneumonia in chest. So don't use these kind of words, pneumonia in chest. Pneumonia doesn't happen anywhere else also.
Commonest illness is URTI, viral URTI, cough, coryza. And that's when her creatinine was 6.2, 5.8 was there earlier. 3 तक आ गया था, you said after delivery, during delivery it rose to 5.8, and then within 2 months it was 3, and then continued to be at 3. LRTI it increased to 6, then 5.8. Again she was seen by a nephrologist, and ANCA and ANA and other tests are done. So what was your diagnosis? If you were treating this patient, what is the presumptive diagnosis?
Neurological diagnosis would be some sort of chronic interstitial nephritis.
What are the points in favor of chronic interstitial nephritis?
So she, before pregnant, pre-pregnant level, she did not have any history of this lower limb swelling. And
She has started dialysis now that she has come here. So now she has a small contracted kidney and advanced renal failure, and you started her on dialysis. Now she has CKD. What do you think is the cause of CKD? वही तब भी था, वही अभी भी है. So that's why I was just cutting short. So when you said chronic interstitial nephritis, why?
she did not have any symptoms of swelling or worsening edema,
Mhm.
calcium-venic edema, which is common in glomerular.
Throughout her pregnancy and later on, you said she has repeated episodes of swelling over feet. Given diuretics, subsided. Again swelling over feet. Given diuretics, subsided. You have a whole history from 1.4 creatinine to ESRD. What else do you need?
And there was proteinuria.
And she also had proteinuria.
Second would be chronic glomerular nephritis.
What is more common? Chronic glomerular nephritis or chronic interstitial nephritis? Chalo, let me reframe your question. If you see 100 patients with end-stage kidney disease who start dialysis, what would be the cause of these 100 patients? How many patients would have what? यार ये तो बता दो. आप बताइए. Diabetes is the commonest cause, so we call it diabetic kidney disease. Okay, that is the commonest cause. Hypertension,
then glomerular nephritis,
chronic glomerular nephritis.
and cystic kidney diseases.
How common?
KDP.
So if you have to give the number, say of 100 patients, how many would have diabetic kidney disease? Approximately 70 to 80%. बाकी सब कहाँ जाएंगे? 50%. Say approximately 45 to 50, or say ballpark figure 50%. Half of them will have diabetic kidney disease. Hypertensive 20 to 30%. Then chronic glomerular nephritis 10. Okay. Chalo. Chronic interstitial nephritis. You said polycystic kidney disease or genetic kidney disease. How common? 10%. 10% generally. And chronic interstitial nephritis is less than 5%. This is USRDS data, right? What is the caveat in this? Any change in our circumstances? Oh, wait. Neeraj?
Some parts such as CKDU, which is more common.
वो एक small belt है, CKDU is a definite entity. Yeah. So there are Indian series where people have noticed that chronic interstitial nephritis is more common in India. The Western figure is 3 to 5%, whereas Indian series have mentioned somewhere around 15%. Okay, it's more common as compared to US data. Right. Part of it is because of CKDU, because of this temperate climate and other things, and partly unknown etiology. Maybe lot of over-the-counter medicines which are available. Lot of them are either Ayurvedic medicines which have heavy metals, or analgesics which patient take. So that is contributing to these high incidence of chronic interstitial nephritis relatively in India. Right. Other caveat is hypertension and chronic glomerular nephritis. How does hypertension cause renal failure? What is the spectrum of patients which you see because of hypertension? What type of patient? Have you made a diagnosis of hypertensive nephrosclerosis? बनाई है? अभी तो किसी ने नहीं बनाई.
आपने बनाई है?
बनाई है? बायोप्सी डायग्नोसिस. क्लिनिकली किसी की डायग्नोसिस हाइपरटेंसिव नेफ्रोस्क्लेरोसिस बनाई है आप लोगों ने? नहीं. बनाई थी डायग्नोसिस? नहीं बनाई थी? बताओ. अगर आपने अभी तक, यू आर इन थर्ड ईयर नाउ, सेकेंड ईयर, थर्ड ईयर, आपने कम से कम 100 पेशेंट तो देखे होंगे ना. तो उसमें कितने पेशेंट की हाइपरटेंसिव नेफ्रोस्क्लेरोसिस डायग्नोसिस थी? फ्यू. अगर नहीं बनाई तो हाउ कैन इट बी सेकेंड कॉमनेस्ट कॉज ऑफ सीकेडी? आप भी तो इसी दुनिया में प्रैक्टिस कर रहे हो ना. तो है नहीं कि आप किसी प्लैनेट पे जाके और प्रैक्टिस कर रहे हो, वहाँ डिफरेंट पॉपुलेशन है. तो क्यों है ऐसी डिस्क्रिपेंसी कि आपको नहीं दिखती? लिटरेचर में मेंशन्ड है इट्स अ कॉमनेस्ट, सेकेंड कॉमनेस्ट कॉज. क्यों भाई? कोई तो बताओ. Late presentation. So usually what happens, where do you make it? The patient who have long standing hypertension, say 20 years, 30 years, now with increased medical care they survive coronary artery disease and everything, and that's when they present with, and that's what you see in elderly age group. आपने पढ़ा है ना, in age more than 50 years, 30 to 40% patients have impaired kidney function. Age more than 80 years, lot of patients have renal failure. So these are the patients who have long-standing hypertension, vascular disease, and hypertensive nephropathy. These are the patients who will require. You see more of these patients in US and Western countries, whereas we don't see such patients very often in India. Although now we see such patients where I make this diagnosis, but not that commonly as we think. That is the reason you don't make this diagnosis. So, lot of patients were labeled hypertensive nephrosclerosis if they do not have any identifiable reason, biopsy was not done, they did not have any history of proteinuria, edema or anything, they presented for the first time with advanced renal failure and started dialysis. You don't know what is that, except that you know that they were hypertensive, they were treated by cardiologists, nobody has ever done creatinine or urine examination in these patients, right, and which is quite common. So these patients are mislabeled as hypertensive nephrosclerosis probably. So that's why there is some overlap. So when you say second commonest cause is hypertensive nephrosclerosis or chronic glomerulonephritis, there may be some patients with chronic glomerulonephritis who are falsely labeled as hypertensive nephropathy. Plus there may be a reason that this is more commonly seen in Western world, whereas we don't see that type of longevity of life and we don't see these patients very often. Okay. So if you talk statistically, chronic kidney disease, first possibility is chronic glomerulonephritis. Okay. Interstitial nephritis is less common, plus you have to have a reason. ये पेशेंट ने कुछ आयुर्वेदिक दवाएं ली हैं, कुछ एनाल्जेसिक्स लिए हैं, कुछ ना कुछ ऐसा फैक्टर है जिसकी वजह से उसको CIN हो रहा है. Chronic glomerulonephritis, what type of chronic glomerulonephritis? Why?
Most of the patients they are detected late in the presentation and
it is the commonest glomerulonephritis, right? It may have a variable presentation ranging from asymptomatic urinary abnormality to rapidly progressive renal failure, right? So patient may have. Lot of patients will just incidentally detected to have asymptomatic urinary abnormality, some RBCs in the urine, cast or some proteinuria or hypertension. Okay. So that is generally, if you would do the biopsy in lot of these patients, if you have done the biopsy after delivery, my guess is 90% you would have find IgA nephropathy. Okay. Second possibility in such patients is reflux nephropathy. Female patient, although there was no positive history in childhood, but that again, that also depends on what is there on ultrasound and urine examination and all. So generally secondary FSGS or reflux nephropathy.
What are the points against CGN in this case? You told shrunken kidneys.
Sorry, I didn't get what?
Sir, shrunken kidneys. He mentioned that in ultrasonography, bilateral shrunken kidneys were there. Just the points against CGN, sir, I was asking.
But that shrunken kidney will be there in any chronic kidney
Yes, sir,
disease. Be it interstitial nephritis. Only thing is in interstitial nephritis, you will, in CGN, you get a regular smooth outline, whereas in interstitial nephritis, it will be irregularly scarred kidney, irregular outline. Right? So, anything, any question anybody wants to ask regarding this case? So, I think in nutshell, it is important to identify renal disease in pregnancy. The patient in pregnancy come for the first time with some abnormality, how to differentiate whether it is chronic hypertension, preeclampsia or chronic kidney disease, and how to manage pregnancy in these patients and kidney disease in these patients. Right? No question?
So what will be the target KPI if the patient is dialysis?
Sorry?
What will be the target? What's the KPI we should target in?
What KT upon V should you target in otherwise non-pregnant patient?
Sir, hemodialysis is 1.2 to 1.4.
Yeah. Why? What if you give them more?
This is the KPI B range which has seen to a lesser mortality and lesser cardiovascular outcome and better survival and better side effect.
So what is the evidence for that? Partly what you said is right, partly it is not right. So if KT upon V is less than 1.1 or say 0.8, it is inadequate and there is very high mortality. That was documented in NCDS study, National Corporation Dialysis Study, right, way back in 80s. So it has to be more than 0.8. Then there are other studies where they have shown no, it is not a step pattern, it's a continuous pattern, right. So even if it is say less than 1.1, there is progressively increasing mortality. That's why it is say minimum you should give 1.1 or say 1.2 KT upon V. There is a discrepancy between what you order and what is delivered. What is single pool KT upon V and what is equilibrated KT upon V, right. That's why it comes to 1.4. So if you target at 1.4, you will end up delivering at least 1.2. Well, there is 20%. So that's why you say you should minimum give 1.4. Now people have tried to increase it beyond 1.4. Let me give them 1.7. Whether it will increase the outcome, improve their outcome. Hemo study was done, which showed that there is no improvement except for volume status, where the higher ultrafiltration was achieved. Cardiovascular comorbidities was less, say cardiovascular mortality, but otherwise there is no improvement in overall mortality in these patients. Other studies, there is data, although observational data, that if you give them more dialysis per week, these patients have better outcome. There is data of nocturnal hemodialysis. People have dialyzed these patients for 6 hours, 7 hours, at least 5 days in a week. So total 35 hours of dialysis in a week. And they have shown that the outcome in these patients are as good as cadaveric kidney transplants. Their survival is as good as cadaveric kidney transplantation. Living donor kidney transplantation is still slightly better. So more you can give dialysis, better is the outcome. What is the problem with giving more? It is intrusive, right? You have to strike a balance between quality of life and their survival. आप कहो जी आप रोज़ाना आइए और 6 घंटे डायलिसिस कराइए, भैया मैं अब तो इसी काम का हो गया था, मेरी ज़िंदगी तो हेल हो गई, मुझे नहीं चाहिए ऐसी ज़िंदगी। आप मेरी ज़िंदगी 2 साल बढ़ा दोगे बट उसमें क्वालिटी तो है ही नहीं, राइट? सो यू हैव टू स्ट्राइक अ बैलेंस between the quality of life and their expected survival. Dialysis is intrusive. So that's where now the concept is patient-centric outcome. See what is the patient goal, what do they want, how much dialysis. You have to make them comfortable, you have to improve the quality of their life, whatever life they have. So now people are moving away from solute-based clearance targets, right? But given that patients in our circumstances, they need dialysis. So generally most of these patients will on twice a week dialysis. If they are not doing well, you should increase it to thrice a week dialysis. During that dialysis, give them as much dialysis as possible. Okay, coming back to pregnancy. Now if the patient is on dialysis and have become pregnant, you should give them as much dialysis as possible to maintain their internal milieu to near normal level. You cannot make it near normal, but as near as possible. So generally people who have managed these patients would dialyze them at least 6 days a week. I have seen such patients when I was there in Toronto. That lady was on dialysis and she had 3 pregnancies during dialysis. And I have managed her through 1 pregnancy. So she was being dialyzed every day. She was on peritoneal dialysis, she conceived, she was switched to hemodialysis, we used to dialyze her every day. And she was carried throughout the pregnancy and had a delivery. So give them as much as possible, practically. Don't just target their KT upon V or creatinine clearance. Did you get the message? Any other question?
Sir, how we manage the UF?
Ultrafiltration. Whatever she would gain, if she is making urine, that is good. If she is not, you have to assess their target weight. We don't call it ideal weight, we call it target weight, right? Which is best for her. You have to adjust this weight according to the pregnancy state. As we have discussed, there is weight gain, so you will frequently have to adjust it. So at least half a kilogram every month or more, depending on your clinical judgment. So as the pregnancy proceeds, you have to increase their target weight, and after delivery again you have to cut down on that target weight and bring them back to what they require.
The UF should not be more than 1500 per session. It should be 5 to 6 ml per kg per hour. These are the recommendations.
So don't over ultrafiltrate them, because every time you do more ultrafiltration, there is episodes of hypotension, and that will also impair the outcome of pregnancy. So you don't want hypotensive, you don't want volume depletion in these patients. Anything else? So if not, then we thank you, Ankit. Nice case you brought. There is a postgraduate course which is organized on 16th March. I think all of you have received that information in the group. So this will be in the form of mock test. So we are doing it in OSCE pattern. You will have spots on histopathology, on radiology, and on clinical problems. You will answer it, and then we will discuss these problems. So what you should see and how you should describe those spots. Okay. So we expect all of you or most of you to be there. Okay. It is in India Hepatitis Center on 16th March 9 o'clock. Okay. Logistics will be worked out. There are people who will come back to you for arrange your transport and everything, but do make a point to attend. Holi is on 14th, so Holi will be over by then. Okay. Thank you.
Thank
Want
you,
to say
sir.
anything?
No, nothing, sir. Thank you very much, sir.